Today we're going to look at coronary heart disease, and specifically when we're thinking about coronary heart disease, we have to think about the underlying processes that lead to coronary heart disease. So initially we're going to talk about atherosclerosis. So that is the buildup of fatty plaques underneath your big blood vessels, so your arteries, how that leads to coronary artery disease, otherwise known as coronary heart disease, and then how it further moves on if things get very significant into a myocardial infarction or an MI. And we'll talk about the processes leading up to an MI, the types of MIs and those precursors. So angina, and you have stable and unstable angina before that MI kind of kicks in. So first, we really need to think about the structure of an artery as a whole and its function, obviously, and that allows you to understand how narrowing of these arteries actually occurs in the first place. So all of our blood vessels, they have endothelial cells lining them. And so those endothelial cells are very, very important because they control the transfer of molecules across the vascular wall. They regulate thrombosis, so the formation of clots. They regulate your inflammatory reactions. So if you get inflammation or damage to tissues, you need to get white blood cells and other factors getting across those endothelial cells and into those tissues. But it's also acting as a barrier to keep circulating factors within the bloodstream itself. So it has some very, very important roles. And so when we're thinking about blood vessels, we know that we've got our arteries, we've got our arterioles into our capillaries, our venules into our veins, and then they all drain back into our heart. But what about the overall structure? Well, most of our blood vessels, not all, have got three layers, and we can see those in this image. You've got the inner layer, so the tunica intima, so that's where your endothelial cells are. You've got your tunica media, so that's in this little area, so it's kind of the one in between, the middle layer. That's got your smooth muscle, and if you think about your arteries, they need to, and your arterioles, they need to expand out when the blood is passed into them, and then they need to recoil back in, and they vasodilate and vasoconstrict, which is all mediated by that muscle tissue. And of course, that elastic tissue, as I've just mentioned, is all about when the blood comes into your arteries, it has to expand out, so it has to kind of bulge outwards to take that extra pressure, and then it has to recoil in. Think of an elastic band. So, like I said, we've got the three main types of blood vessels, your arteries, your veins, and your capillaries. And you can see that the arterial walls, if you're looking at these, they're much, much thicker. And that's to accommodate that pulsatile blood flow and the much higher blood pressures that are occurring due to the transfer of our nutrients, or of our blood rather, coming from the heart. The veins are much thinner walled, and that's because they have much lower pressures. And then you've got the capillaries, which are really, they've just got a little basement membrane giving some integrity, and they've got the endothelial cells. And remember, it's our capillaries that allow nutrients, so your glucoses, amino acids, oxygen, small molecules to leave the blood and get to the tissues themselves. So here's a nice little video of coronary heart disease, or what has actually been seen coming out of an aorta of someone who was, in this case, a smoker. But the key thing about this is that coronary heart disease is one of the UK's leading causes of death. About 60 to 70,000 deaths every year because of coronary heart disease and its associated factors. And so that means works out at about 1 in every 8 minutes or so. So let's see if this works.
Every cigarette is doing you damage. This is part of an aorta, the main artery from the heart. Smoking makes arterioles sticky and collect dangerous fatty deposits. This much was found stuck to the aorta wall of a smoker, age 32. Every cigarette is doing you damage.
Authorised by the Australian Government, Canberra.
Okay, so it's just to kind of show what's actually occurring in your big blood vessels if leading. It's not just smoking. There are lots of lifestyle factors as well as genetics involved in this process. But a key thing is that you get narrowing of your big blood vessels because of atherosclerotic plaques that start to form underneath those endothelial cells. So what is it? Well, it's characterized initially by the endothelial cells not functioning properly. And when they don't function properly, of course, they can get a little bit leaky. So things can start to get underneath those endothelial cells. And what gets under those endothelial cells is fatty deposits. And then over time, you get kind of a plaque or fibrotic tissue forming over the top of those narrowings of those plaques. So in essence, atherosclerosis, you're getting deposits of lipids, in particular LDL cholesterol, which is your bad cholesterol, various cell waste products, calcium, that fibrotic material. And eventually, as the development goes on, the plaques may cause an artery to become so narrowed that blood flow is impeded, and therefore you're not getting as much oxygen getting to the tissues. And if that tissue, in the case of the heart, isn't getting enough tissue, enough blood and nutrients, it can't function properly. And so where does it come from? Well, it comes from the word athero for porridge, sclerosis for scarring. And here you can see a nice little image. Here's a nice normal coronary artery. Here's your narrowing of it, because this is your lipid buildup underneath the endothelial cells. And then if those narrowings burst and you get a blood sea, release all that fatty material into the blood vessels, that causes a clot to form, and therefore you can get blockage to that coronary artery. And if you look at this little image, if you get a blockage in this coronary artery down at this point, all of the blood vessels, or all of the region of the heart that's being delivered by that blood vessel is therefore no longer getting the nutrients, and if the blockage lasts too long, can go on to die. And so it's important to note, we're talking about coronary heart disease, we're thinking about coronary arteries, but of course atherosclerosis can affect any big blood vessel. So in the heart, a blockage can lead to an MI. In the brain, it can lead to a stroke, and the renal artery, obviously, it can lead to renal failure. And key thing, like I said, atherosclerosis is the main underlying cause of cardiovascular disease in Western countries. So what's happening in the great scheme of things? So here's your healthy artery. Here are your little fatty streaks that you start to form, and they start to form very early in life, within the first decade. You then start to get more fat and you get a fibrotic plaque, so a kind of fibrotic tissue going over the top of it. And then they become what's called complicated plaques when they really have narrowed. So you're starting to get serious effects, ischemic effects, where you're not getting enough blood going to the heart. And of course, these can go on to potentially clot as well. So when you get one of those ischemic events, where you get a blockage or a narrowing of this blood vessel that is significant enough to give you symptoms, that lack of oxygen and nutrients can give cell damage, and that can often lead to pain. So pain, you might be getting a buildup of lactic acid and other metabolites that are building up because you're not getting enough oxygen and nutrients. That can cause some pain, and if it's over a prolonged or extended period, that can lead to cardiac death. So your myocytes, your muscle cells dying. When does it actually kick in? Well, it's interesting because you start to see these little fatty streaks forming very, very early in life, within the first few years. So within 5 to 10 years of age, you're starting to see these slight narrowings. Now, that's not significant in that it's not going to have any effect in the great scheme of blood delivery to the organ, in the case that we're thinking about the heart, but the process is beginning. So, and like I said, age doesn't normally clinically manifest until late to mid-age, and that's what you're seeing down in here. You're seeing it ages 10 to 20, your fatty streaks start to expand, and you start to get a plaque, so this fibrotic tissue forming over the top of it. They then enlarge, so you can see they're getting bigger, and then they go on to form these complicated plaques where symptoms might start to appear. Now, there are lots of risk factors. Some you're stuck with. So your genetics, you can't do anything about. Your age or your sex or your family history, you can't do anything about those. Your lipid profile, so that's how much LDL, so bad cholesterol have you got, how much HDL, which is your good cholesterol have you got. So there's predisposition to levels of those, but also they are adaptable. You can take drugs for one thing, obviously, but you can also change your lifestyle, which will hopefully reduce your bad cholesterol, your LDL, and increase your good cholesterol, your HDL. The other things that happen, obviously, are your activity levels. That tends to, in most people, lower the bad cholesterol. Hypertension is a risk factor for atherosclerosis, as are smoking, vaping, being overweight, obesity, diabetes mellitus, and a variety of other conditions. And so in thinking about diabetes, diabetics tend to have persistently elevated glucose. Even if it's well controlled, their blood glucoses will tend to be higher over the longer term. And that excess glucose binds to those endothelial cells, changes the function and structure, some of the proteins on the surface, leading to that risk factor or increased risk factor of atherosclerosis. So what is the trigger for atherosclerosis? Well, I've already said that we start to get them really at quite a young age. So those are triggers. Well, you have those natural triggers where it's just a process within aging, so to speak. But there are things that activate and trigger the process to accelerate. And I guess that's what we're really thinking about. So the triggering events, really, we need damage to the endothelial cells themselves. That is the underlying thing that happens. Remember, these is your tunica intima. This is where your endothelial cells are. And this is where we get the damage in the first place, which will let all the nasty lipids get underneath them and a plaque to start to form. So there are a variety of things that can trigger it. Mechanical trauma. So that'll be your hypertension. Just imagine that high pressure coming through your arteries, whacking against those walls, causing all that turbulence and leading to damage of those endothelial cells. You've got high plasma LDL or glucose levels. So again, the glucose is very toxic at higher levels. So it binds to the endothelial cells, changing their structure, changing their function. Your high LDL accelerates that atherosclerotic plaque formation, as we'll talk about shortly. You may have circulating toxins from regular infections and viruses, or from a variety of tobacco products. Remembering, of course, we talk about throwing in tobacco and vaping in there, but tobacco is the bad one because it has thousands of chemicals in it. Vaping, recent information suggests, or kind of suggests that vaping is 95% safer, if you like, than regular tobacco. So it's only got a 5% of that extra risk that tobacco has. So much better than tobacco, doesn't get rid of all the risk, but it is a lot less harmful. So what's actually happening? So whatever's happening over that longer term, we're getting damage to those endothelial cells. Those cells, because they're being damaged, they get increased permeability. And that just means things can start to leak in from the blood and underneath the tunica intima and into the inner part of the tunica media. Remember, that's where your smooth muscle cells and your elastic fibers are. And so one of the things that ends there initially is your LDL. That's your low density lipoprotein or your bad cholesterol. That LDL becomes oxidized. And it becomes oxidized because there are macrophages within there, there are enzymes, there are metabolic waste products from these cells. All of those things oxidize that LDL, make it smaller, and make it much nastier. And that oxidized LDL in itself is causing damage to the endothelial cells. So you've got this vicious cycle occurring. But at the same time, these damaged endothelial cells, sensing something is wrong, they start to produce what are called cell surface adhesion molecules. So these are just proteins that come to the surface of the endothelial cells, and they allow your circulating monocytes, which are the white blood cells, the immune system cells that are floating around in the blood or being transported around in the blood, that go around gobbling up things, any viruses, bacteria, toxins, whatever it might be, they go and eat them. And so these monocytes start to adhere to the surface. And as they adhere to the surface, they then go underneath the surface into the tunica media where the LDL is and start to eat that LDL, because you don't really want that oxidized LDL sitting there forming these pools of lipid. And so these form really over time quite large, what are called foam cells, and they're basically macrophages. So monocytes are in the white blood, in the blood. When they get into the tissue, which they're doing in here, they become macrophages, and they're just becoming larger and larger, and they're called foam cells, and they're just filled with fat, with LDL cholesterol. So really what is happening is in the earliest stages, we're just getting, you can see in this little image, you're getting just little foam cells forming. So remember, this is the macrophages ingesting the oxidized LDL within that arterial intimate kind of region, and they just become lipid laden. We then start to form a fatty streak. So these foam cells are starting to accumulate beneath the endothelium, causes minimal narrowing, so not really anything nasty happening, but we're starting to get plaques form on the top of them. We then go into the pre-atheroma and atheroma stage, and this is where the intracellular lipid begins to accumulate. So you can see this little yellow plaques here, and this much bigger area here. So this is like it's called a lipid core. So as the foam cells, these macrophages that have eaten all that lipid, start to die, they release their content, and you get this lipid pool forming within the intima and initiating that plaque formation. Then you go, so then you've got over time as that lipid core forms, that leads to thickening of the arterial wall, as you can see, and lumen narrowing, and you start to get a fibrotic plaque forming over the top of it. And that's really just down to smooth muscle cells, which are here, all starting to proliferate, depositing collagen and other fibrotic material, forming a cap over the top of that lipid pool. So we're starting to get really serious narrowing of our main arteries going at this point. And finally, you'll hit what's called a complicated lesion. So this is where you might get rupture or erosion of this fibrotic cap, which is kind of protecting the lipid pool, stopping it get out. That exposes that thrombotic material, that lipid core, and that triggers a clot core formation, which can acutely obstruct that blood vessel. And that's when you get those clinical events. So just as a reminder, it's the coronary arteries supply the myocardium with oxygen and nutrients. And so here you can see the blood coming into the aorta. So from the left ventricle into the aorta, here are your left and your right coronary arteries. And you can see the first place blood goes to as it enters the aorta is nicely down into these coronary arteries. Okay, so they're getting an immediate supply of oxygenated blood and lots of nutrients. And if you get a blockage, like we said, to one of these coronary arteries, you get reduced blood flow, damage and death of the cells within the heart, thinking about the myocytes in particular, and that can lead to your myocardial infarction, which is commonly known as a heart attack. But when we're thinking about here, we're saying myo for muscle, cardial for cardiac system, infarct, which is death. Okay, so death of the myocardium, death of the muscle cells. So what I'd like you to do is just take a little look at this table and try and give a definition of what you think stable angina is, unstable angina, MI, and then ischemic cardiomyopathy. Now, I know it might be quite challenging, but just thinking that we're starting at the least nasty to kind of the nastiest. So it's going in kind of progression of nastiness. So what I'd like you to do is press pause, try and think through those questions, give a definition that you think is right. We'll go through it anyway. Yeah, then we'll go through it. So press pause. Okay, so I hope you've done all of that. I hope you pressed pause and weren't just waiting for me to start yabbering on again. So stable angina, what is stable angina? Well, this is chest pain due to temporary reduced blood flow, and it is usually predictable. So in other words, symptoms usually occur during physical exertion or emotional stress, and they are relieved by rest. There are drugs that you can take, so glycerol trinitrate is one, but they tend to be relieved by rest, and it's predictable. So you might be walking up the stairs, you might be getting really, really anxious, and so you're getting that increased blood flow going to the heart, but the arteries are too narrowed, so not enough blood is getting there, so that gives you that chest pain on exertion. But when you rest, it all gets better. Unstable angina. This is chest pain due to reduced blood flow occurring unpredictably. Okay, so symptoms can occur at rest, and they can indicate an increased risk of progression to MI, which is that next stage. So we've gone stable angina, you know when it's going to kick in. Unstable, it could just be at any point. And then we go into myocardial infarction, where we're getting death of heart muscle cells due to prolonged lack of blood supply. So the key point, the difference, I guess, with unstable angina is you're getting chest pain due to reduced blood flow occurring unpredictably. The same with an MI. The difference is an MI, you get death of heart muscle cells because the whole thing is prolonged lack of blood supply. Whereas unstable angina, you recover before you get death to those heart muscle cells. And the key thing again is that permanent damage to heart muscles becomes because cardiac muscles cannot regenerate after that prolonged ischemia. So they can't regenerate themselves. You can't just keep going to make new ones. And finally, we've got ischemic cardiomyopathy, which is long-term reduced blood supply is leading to a weakened heart muscle and reduced pumping ability. And so it often results in heart failure. So it's that next step. You've repeatedly weakened that heart muscle due to repeated ischemia or infarction, meaning you can go into heart failure, where the heart just cannot pump effectively anymore. I'd also like you to just think, what do you know about sudden cardiac death? So it's something that's in the press quite a lot, that you hear about younger athletes during an endurance event suddenly fall over, collapse, and pass away. So that's your sudden cardiac death. I'd just like you to think, what do you think the actual cause of that is? Is it due to atherosclerosis and coronary heart disease, or is it due to something else? Just have a think. What do you know? Okay, well, I hope you pressed pause, because if you didn't have a lot of time to think about that. So usually it's actually due to undetected structural or electrical heart abnormalities, and that causes your fatal arrhythmias during intense exertion. So the key point is the trigger is intense physical exertion, and it isn't down to atherosclerosis and inherent coronary heart disease. Okay, so now we're just going to go through each of the types of coronary heart disease that we've spoken about, so angina, MI, and then we'll just give a little bit of a kind of an overview to each one. So angina is pain associated due to myocardial ischemia. So we're not getting enough blood coming to the heart muscle tissue. The pain tends to last 3 or 4 minutes. It can radiate to a multitude of different places, to the neck, lower jaw, left arm, shoulder, but the pain recedes and the heart is not permanently damaged. And the key thing is it's all about sudden oxygen demand. So for example, exercise or stress can lead to this angina just because not enough nutrients can be delivered. What is the cause? Well, it's the atherosclerosis gradually occluding the coronary artery. And like I said, that sudden increase in oxygen demand leads to angina. So what's actually happening? Well, you're getting reduced coronary blood flow. So that means the heart muscle itself isn't getting enough nutrients, not enough oxygen, not enough glucose. And that reduced oxygen delivery leads to a buildup of lactic acid. So basically the heart tissue, it's got small reserves of glucose in there, starts to work anaerobically. Lactic acid starts to build up. That irritates those myocardial nerve fibers, enters the spinal cord, and that gives you that pain. And it can enter the spinal cord at different levels of the spinal cord, which is why the brain can get a bit confused as to where the actual pain is. So obviously the damage is being done in the heart, but you might feel it in a multitude of little places. And that's because your sympathetic nerve fibers enter the spinal cord at different levels. So it happens to be from C3 to cervical 3 to thoracic 4 to T4. So that just accounts for the variety of locations and radiation patterns. And of course, like we said, that pain is usually relieved by rest or the use of nitrates. So remember that glyceryl trinitrate. So when you're getting angina, you want stable angina. I mean, you don't want either of them, let's be honest. But if you're going to have one, you want stable angina as opposed to unstable angina. So stable angina, which is your classic angina, is caused by this gradual luminal narrowing and hardening of the arterial walls. And that causes the affected vessels not being able to dilate in response to increased myocardial demand. That's associated with physical exertion. So in other words, you need more oxygen. They don't really, the coronary arteries don't dilate a huge amount, but what happens is you get that increased requirement coming in, but they're so narrowed that not enough nutrients can get in, meaning that they become, that cardiac tissue becomes deficient in oxygen and glucose. So you're not getting that pain and discomfort associated is usually relieved, like we said, by rest. So the key thing about this is you have a fixed stenosis. So you have a stable, what's called a stable plaque. So it's fairly resistant to rupture. So it's less likely to rupture, release some of its contents, and a clot to form. It's demand led, so it's kind of predictable. You know that it might be down to running up the stairs or anxiety or stress or anything like that. So it's related to effort, and you have those symptoms over the longer term. And like I said, that's your classic angina. You then have unstable angina, and that is caused by rupture of an atherosclerotic plaque. And so when that plaque ruptures, platelets begin sticking to that underlying tissue of lipid and gunk and forms a clot that can completely or incompletely occlude the vessel. But usually in unstable angina, that clot is then kind of disappears or is no longer there, and blood returns, and so that pain recedes. So Again, in contrast to stable angina, in contrast to stable angina, unstable angina symptoms occur at random and unpredictably. And so, like I said, it occurs when a plaque becomes unstable and a thrombus, a clot, partially or intermittently reduces blood flow. So you're not getting, the key thing is you're not getting death to the tissue itself. That's the next one, which is your myocardial infarction. So you're not getting sufficient blockage for a sufficient amount of time to completely kill the tissues. So it causes that ischemia at rest or minimal exertion, but doesn't cause cell death. So it occurs unpredictably. And it's a very similar mechanism to an MI, but like I said, it's really key, no permanent damage to the heart muscle. So how do you reduce the risk of angina? Well, you try and eliminate those risk factors. So it's the same when you're thinking about hypertension, which we've got a previous podcast on, thinking about the risk factors for that. It's very similar to this. So some people will be taking aspirin, and that aspirin at very low levels inhibits platelet aggregation, therefore reducing the risk of a clot from forming. You might rest. That when you rest, you get reduced oxygen demand. And nitrates, so that's your glyceryl trinitrate that I keep talking on about. So remember, endothelial cells produce nitric oxide, which is a vasodilator. And so when people take GTN or your nitrates, they cause venodilation. So a key thing is, in this, the nitrates don't significantly dilate your coronary arteries. So that is not the mechanism that's happening, okay? In fact, they don't do any arteries to any significant degree. They do vasodilate arterioles, but that doesn't really help us in this case because it's the arteries that are blocked, okay? So we can give nitrates and go, oh, look, that'll cause vasodilation of the arterioles within the heart. Yeah, it will, but actually that's not where the issue is. The issue is in the arteries, and really we don't get huge amounts of vasodilation and vasoconstriction in the arteries themselves. Most of it takes place in the arterioles. So nitrates work by venodilation. So the first thing they do is on those blood vessels, the endothelial cells, they release the nitrates, act on the smooth muscle, causing venodilation. So with that venodilation, you're getting more blood being held in the veins. And the veins are like a storage place for blood. It's like an unofficial storage place for our blood. And so with more blood being held in the veins, less blood is going back to the heart. And as less blood is coming back to the heart, there's less stretch of the heart. There's less blood in it, so it's not stretching as much. Therefore, there's not as much stress. And that reduced filling of the ventricle lowers that myocardial wall stress during contraction. But at the same time, because it's not being as stretched, it doesn't need to contract as hard. And if it doesn't need to contract as hard, it doesn't need as much oxygen. So therefore, as it doesn't need as much oxygen, less blood needs to go through the coronary arteries themselves because the myocardium doesn't need as much oxygen. And so that's why you get that relief. You basically get venodilation, less blood goes to the heart doesn't have to work as hard, so it doesn't need as much oxygen, so you get angina relief. So here's a little review question for you. So I'd like you to read through the question, think about the answer. So yeah, just one is correct. So press pause, read the question, then we'll go through it. Okay. A 55-year-old woman has elevated LDL cholesterol and a long history of hypertension. Early imaging of her artery shows thickening of the arterial walls. So which process initiates atherosclerosis? So what is the first thing that kicks off to make atherosclerosis actually occur? So is it A, B, C, or D? Now, hopefully you all said B, which is endothelial injury allowing infiltration. Remember, the very first thing, the initiating event that allows LDL and inflammatory cells to enter the intima and therefore starting that plaque formation is the endothelial cells becoming damaged themselves. So what about A? Well, chronic inflammation that contributes to plaque formation but occurs after endothelial injury. What about fibrous cap? That is part of the later plaque maturation, not an initiating step. And the fatty streak, again, that occurs immediately after that endothelial injury. So you get that foam cells forming and then the fatty streak forming. So what we're going to look at next is myocardial infarction. Okay, and so that's where we're getting longer or prolonged blockage to a coronary artery, leading to damage and death to the downstream muscle cells. So remembering myocardium necrosis or death, that's uncontrolled death, occurs after the coronary artery flow is interrupted for an extended period of time. So you might get coronary artery being blocked. That downstream tissue, so down here in this case, starts to become hypoxic, so it's not got enough oxygen, and that hypoxia starts to lead to myocardium damage. Now, early on, it starts to work anaerobically to give you lactic acid and therefore start to give you pain. Thinking, of course, lactic acid being an acid is toxic. Remembering, of course, that other metabolites are also going to be released. That isn't just lactic acid. Likewise, it isn't just lactic acid that's giving you those symptoms of pain. Lots of other mediators are also being released, but this is the easiest one to kind of think your way through. So they're probably they're still in this earlier stage. So you're getting a bit of pain, but they're still the myocardium is still viable. It takes a prolonged period for it to lose that viability. But we are starting to lose contractility because we're not getting enough oxygen and nutrients coming to this bit of the heart. So it isn't functioning as well as it should do. And if it's not functioning as well as it should do, you're starting to produce or reduce that pumping capacity. So it can't pump as much up. And of course, your sympathetic nervous system will kick in then to say, hey, I'm not pumping enough blood. What can I do about this? And so it'll try and make the heart work harder. So it'll try and increase contractility and increase its rate. But of course, it's not getting enough oxygen. So it's this whole vicious cycle of not really being able to recover. If that blood delivery is reduced for a prolonged period of time, that's when you start to get that cell death and necrosis. And over time, you start to get scar tissue forming. So scar tissue is not good because scar tissue is not contractile, so it's not going to be able to contract, but it's also not going to be able to transmit those electrical currents that you see in a classic ECG. Those electrical currents are going to change because it's scar tissue there. Electrical currents don't go through scar tissue very well, so everything's going to slow that electrical transmission will slow down. And of course, with that cell death and necrosis, myocardium loses more contractility, reduced pumping capacity, leading potentially over time, if you live through the MI or subsequent MIs, lead to reduced pumping capacity over the longer term and heart failure. Remembering that necrosis leads to scar tissue formation over time of that affected myocardium, and therefore you can get heart failure potentially and arrhythmias. Again, the arrhythmias because the electrical activation or electrical signaling not being appropriate. So thinking about myocardial infarction, there are two main types: the STEMI, which is the worst one, and non-STEMI, which is the less bad one, but still bad. And so MI is myocardial infarction, and STEMI just means ST elevation. So that's an elevation on an ECG of the ST region. And in a non-STEMI, obviously, you don't get that ST elevation. So when you look at someone, if someone comes into the accident and emergency department or the emergency department with a suspected MI, they'll do a couple of things. They'll take some blood tests. They'll ensure they're alive, obviously, and help them if as needed. But the things that they'll measure an ECG and they'll measure a troponin, which is a blood marker of an MI. And so the ECG pattern can suggest which region is affected and help to distinguish between STEMI and non-STEMI. So just looking at this, trying to think back about the ECG that you already know, is this ECG pattern a STEMI or a non-STEMI? So press pause, have a little bit of a think about what's happening at each stage, and yeah, just STEMI or non-STEMI. Okay, so let's have a little bit of a think about it. So looking at this, you can see here's your classic P wave, here's your QRS, and here's your T. And you can see that it's elevated. So this ST is elevated. So this is a STEMI or a ST elevation MI. And you can see there it is, there it is, there it is, there it is. So a STEMI make up about 30 to 40% of all myocardial infarctions, and non-STEMIs obviously make up the other 60 or 70%. And it's caused by a complete obstruction of a coronary artery, resulting in tissue damage and necrosis. Remember, when you do an ECG, you have what's called a 12-lead ECG, and that 12-lead ECG is looking in different directions within the heart. So an ECG will help to provide information as to what part of the heart is damaged. So is it in the left coronary artery, the right, or is it into a left descending artery, anterior descending artery, etc. So that location will help to tell you whereabouts the damage actually is. And so that's your STEMI. And then a non-STEMI, like we said, a STEMI is an ST elevation. In a non-STEMI, this isn't a complete obstruction, reducing in tissue damage caused by a partial or intermittent obstruction of a coronary artery, resulting in tissue damage. We're still getting damage. That's the key thing. We're still getting death of cells, just not as significant as a STEMI. And what you'll often see in an ECG in a non-STEMI is an ST depression. Nice and easy to remember. In a STEMI, ST elevation. In a non-STEMI, it's often a depression, and you'll often see a T inversion as well. So it's kind of, if you want to think of it, of trying to remember it, that's quite an easy way of thinking about it. So like I said, an ECG can be used to determine the type of an MI. So here's your P, Q or ST, your normal. Here's your STEMI, ST elevation. Here's a non-STEMI with a ST depression and with a T inversion. The other thing that we've talked about is that troponin. So troponin is an enzyme involved in muscle contraction within the heart, and any cells that die release their products into the blood. And that doesn't matter what tissue it is. But because troponin is specific to heart muscle cells, if you detect that in the blood, it tells you that your heart muscle cells have died. And as you'd expect, the more troponin, the more death, or the more cell death. So here's just an example of your levels. You've got very high levels, a large MI. Lower levels of troponin, a moderate MI. Small levels of troponin, a small MI. So we've talked about this already a little bit. So when we talked about angina, but the classic signs of an MI, they're more severe. So they're severe, it's prolonged, and it's a crushing pain. You're activating your sympathetic nervous system. So you start to feel nauseous, you may be vomiting, you feel cool with clammy skin, with sweating, you become white, and you become short of breath. So, and a key thing is you become really anxious, and that anxiety triggers the sympathetic nervous system, which stimulates the heart to contract harder and faster, and that is not a good thing when you've had an MI. So anxiety is a key thing, or stress is a key thing to try and reduce in someone who has had an MI. Pain tends to be similar to angina, but more severe and prolonged. And just like we said before, it can locate in many, many locations. The damage is in the heart, obviously, but the brain up here just can interpret it as being in different places, because the myocyte, the nerve fibers coming from the heart rather, can come in at multiple different locations in the spinal cord. They go up to the brain, and the brain then isn't really sure where it's coming from. So like we said, you risk reduction and treatment. A healthy lifestyle makes a big difference. So stop your smoking, regular physical activity, reduce your blood pressure, which these will do as well, but also, of course, reducing blood pressure with antihypertensive. If you're diabetic, controlling blood glucose, you may want to be taking aspirin to try and reduce platelet clotting, and you treat with your nitrates. Remember, that causes venodilation. And surgical options include bypass grafts, and that's really, it's also known as heart bypass, and it's just really even a single bypass. You can see here, you're just taking the blood from the artery before the block, so say the block is here, taking it from there and bypassing it. So you're bypassing the damaged bit. In a double or a triple or a quadruple, you're just going past the clot and avoiding the clot. And it just aims to restore normal blood flow to an obstructed artery. So again, have a little look at this question and then press or rather press pause first, have a look at this question, then we'll go through it. Okay. 60-year-old man experienced a 12-minute episode of chest pain at rest that then resolves completely. A troponin level measured 24 hours after symptom onset is normal. So which best describes this episode? So was it A, B, C, or D? Now, hopefully you said it was D, an unstable angina with transient coronary thrombosis and no MI. Remember, because the troponin level is normal, so or undetectable, if you want to call it that, it means you haven't got any cardiac death going on. So it can't be a non-STEMI, a non-ST elevation MI with necrosis because we haven't got death. It can't be an ST elevated myocardial infarction due to complete occlusion because, again, for the same reason we got a negative troponin, so we haven't got cell death. Could it be stable angina due to partial coronary occlusion? No, because in this episode, it was chest pain at rest. Okay, remember, stable angina is predictable and it's stable and it's chest pain on exertion or on stress or something that increases that oxygen requirement of the heart. So the only one that's left is unstable, which is pain that is unpredictable, so occurs at rest and then resolves. Okay, same thing. Press pause and read through this question. Okay, a 58-year-old man with stable angina develops chest pain while walking uphill. He takes sublingual nitrates, that's under the tongue, and his chest pain rapidly improves. Which is the main mechanism for angina relief in this situation? Okay, so A, B, C, or D. Hopefully you said B. So nitrates decrease the amount of blood returning to the heart, lowering its oxygen requirements. Yes, that is the one. Remember, it causes venodilation. So more blood stays in the veins, less goes back to the heart. The heart therefore doesn't have to contract as strongly, meaning it needs less oxygen, which means you don't get the chest pain because you don't need as much oxygen.